Speak it out because I cannot see the chat. Screen is visible or not?
Yes, Doctor.
Okay. We'll discuss the intracranial tumors or the brain tumors, and I'll discuss the different classifications and what are the clinical presentation and what are the medical and surgical management of these tumors. Okay. For brain tumor classification, we use the WHO grading. The WHO grading of the brain tumor is 4 grades, and out of these, grade 1 is considered as the benign variety of the tumors of the brain, and grade 4 is the definitive malignant variety, like the glioblastomas. So 4 are the malignant varieties and 1 are the definite benign varieties, and the 2 and 3 grades, they are in between the two varieties. So the histological grading of these tumor is dependent on this grading, that if it is grade 1, we consider it as the benign. If it is 4, it is malignant, and if it is 2, 3, it is in between the 2 grades. It could be benign, it could be malignant. Now, clinical presentation. Sorry. Okay. Classification can be dependent on the source. Source can be primary or secondary. Primary means a tumor that is arising from within the brain matter. A tumor that is originally primarily from the brain, we call it the primary brain tumor. And secondary are the brain tumors that are in some other areas of the body, and then they metastasize to the brain. We call them the secondary brain tumors. And comparatively, the primary brain tumors are very common as compared to the secondary. About 80% of the tumors of the brain, they are primary. Then the tumors can be classified based on the location. It can be classified as supratentorial lesions or supratentorial malignancies, or the infratentorial tumors, or the infratentorial cancers. They can be based on the histological behavior, histology or the behavior, that we have already said that they can be of different grades, 1, 2, 3, 4, and the benign variety and the malignant variety can be based on their histological behavior, histological appearance, and biological behavior. Clinical presentation. Clinical presentation most commonly is progressive neurological deficit. It is in 70% of the cases. Some patient in about half of the patients, headache is also a very common symptom, and in 30% of the cases, patient may present as seizures, having some seizures activity. And symptoms, we can classify them depending on the intracranial pressure level. Symptoms can be related to the intracranial pressure related ones, or they can be non-intracranial pressure related symptoms. High intracranial pressure symptom related symptoms are headache, nausea and vomiting, loss of consciousness, papilledema, and we have already discussed these before. Just keep it in mind, this linear strip that is shown here. There is actually a balance between the CSF and the blood within the skull, because this is to maintain the integrity and the flow of the blood to the brain. If there is some mass lesion that is causing compression on the brain, that causes compression of the or that causes effect on the CSF and the blood, and that can cause a problem in that specific channel or that specific area. So there are some symptoms that are related to the mass lesions itself. Where is it located? It's itself pressure symptoms, and there is the effect on the intracranial pressure. If the intracranial pressure is relatively affected with it, it is high, then the symptoms are secondary to that also. So this mass lesions has both the symptoms. Depending on its location, the symptoms are changed also. So the non intracranial, The non-intracranial pressure related symptoms are neurological deficit, and it depends on the site of the tumor. There may be affected site weakness, affected site numbness, and visual impairment. This could be seizures, the mental state changes like confusion, speech impairment, depression, etc., or hormones related changes. If there are there is effect on the hypothalamus and pituitary axis, there may be a problem in uh, the amount of the hormones that are produced. Like in pituitary adenoma, the amount of the secretion of pituitary glands, they are high, and they causes the symptoms because of it. So the symptoms can be uh, um, depending on the location, the area from which it has originated, and of the symptoms of the intracranial pressure, the raised intracranial pressure. Now, how can a tumor cause raised intracranial pressure? It causes by tumor's volume itself. When it is causing, when the tumor size is expanding, it is causing the ventricles to become occluded, and the pressure is increased. It can cause edema, and the pressure can be increased because of the cerebral edema. And sometime it causes blockade of the circulation within the CSF. This CSF has its pathway starting from the lateral ventricle into the third ventricle, and then it goes down, and then it is flowed back. So it is a continuous circle of the CSF flow. But if that flow is blocked, there is accumulation, or there is increased in the pressure of the intracranial fluid, and a patient may present, if it is child, it can present as hydrocephalus. Okay, cerebral edema. Cerebral edema, the symptoms because of cerebral edema can be this presentation of cerebral edema can be because of two reasons. The one reason is the direct effect of the tumor, that is the cytotoxic effect, and it is related to the cell death, and it is seen in patients with stroke and acute trauma. But in patients with mass lesions, there is vasogenic edema because of the disruption of the blood-brain barrier, and because of the extravasation of the fluid into the extracellular space, or the fluid leak, that causes the cerebral edema because of the vasogenic reason. So the vasogenic edema is seen in brain tumors. It can be seen in inflammation and infection. So brain tumor is not the only cause of vasogenic edema, cerebral edema. And most brain tumors, they secrete factor, the vascular endothelial growth factor. And this vascular endothelial growth factor, it is related to the weakness or disruption of the blood-brain barrier. It weakens the blood-brain barrier, and actually it acts on the junctions between the cells, and it affects those junctions, and the blood-brain barrier is affected, and in this way it causes edema of the affected area. So the VEGF, it weakens the blood-brain barrier by acting on the tight junctions, and it causes the development of the vasogenic edema. Now, any patient presenting to you with headache, with some neurological deficit, or with sign and symptoms of raised intracranial pressure, detailed history is needed. Ask about the symptoms, duration, ask about the course of illness, how it started and how it progressed, and what is the progress over the passage of time. Ask about the other associated features. Ask about the signs of the intracranial pressure increase, and the signs of the mass effect of that lesion. Ask about the risk factors, if the patient is prone to have such a problem, or any history of such problem in the family. Then a detailed examination is needed. This examination is not only the detailed general examination, as well as the detailed neurological examination to identify or to localize the area of that space occupying lesion, or what is the area of that space occupying lesion. Now, For investigations, we have different modalities available. Imaging, CT scan can be the first line investigation, but the best imaging modality is MRI. MRI is the to identify the parenchymal changes, to identify the effect on the central structures, or the shifting of the midline. It is best seen in MRI. CT is also helpful, but CT is more beneficial in picking up the problems in trauma patients where there is bleeding. Chest x-rays are also advised, and to rule out the secondaries, to rule out the primary, if you're suspecting secondaries, have to go for CT chest, abdomen, and pelvis. Management is, don't just diagnose, we have to manage the patient. Even if the patient is having a tumor of some specific area and you cannot treat it, you have to give the symptomatic control to the patient, give the seizure control. We use many anti-epileptic agents. To control edema, we use dexamethasone. As dexamethasone, it surpasses or it decreases the activity of the vascular endothelial growth factor. And then we can go for surgical management, like we can, if the area is tumor is accessible, we can go for a total resection if it is curable, or we can go for debulking if it is uncurable lesion. Debulking is usually done in big tumors that are causing mass effect and they are not curable. And that's also one of the way of getting the the histological diagnosis. Okay. Now, one by one, we'll discuss these tumors in detail. So the common adult brain tumors are astrocytoma and meningiomas. Astrocytoma is the most common primary brain tumor in adults, and it arises from astrocytes in the white matter, and it can range from grade 1 to grade 4. The grade 4 variety of astrocytoma is called glioblastoma multiforme, and it is the most common malignant tumor. Okay, now the glioblastoma, it is a WHA grade 4 astrocytoma. It is the most common malignant brain tumor in adults, and it represents about 50% of all astrocytoma. Usually it is located supratentorially. If you talk about the location, usually they are in the supratentorial region. They have subacute presentation. It takes about weeks to months to develop the symptoms after the appearance of the malignant lesion. And surrounding edema is common. Uh, Clinical presentation can be in the form of neurological deficit of the affected area, seizures, and sign and symptoms of raised intracranial pressure. Diagnosis is by history. We take a detailed history, and just like we discussed before, that you have to take all the aspects of the thing in the history, and then a complete physical, general physical, as well as a complete neurological examination. And for investigation, the best investigation that helps us in ruling out the problem is the MRI. Management is, we have to manage the patient, not the imaging. Whatever is the imaging picture, if it is inaccessible, we cannot leave the patient. If sometimes the lesion is too much deep that we cannot access it, or if it is too close to the vital structure that we cannot operate it, still you have to treat the patient. You have to give symptomatic control to the patient. If there are scissors, control the scissors. If there is edema, just a bit, I think. Yeah. If there is edema, you have to go for edema control. I have to give dexamethasone. Why dexamethasone? As we have told that it is vascular endothelial growth factor, which is responsible for the vasogenic edema, and this dexamethasone is causing its reduced activity of that growth factor. Then general workup of the patient to rule out its to check for the resectability as well as for operability of the patient. And necessary imaging studies, all the necessary imaging studies. And management is, if the lesion is accessible, go for surgical resection. And If needed, we can go for chemoradiotherapy. Sometimes we give it as an adjuvant therapy, or sometimes we give it as a new adjuvant therapy to reduce the size of the tumor. If there is, you cannot take out the tumor for by resecting, as the tumor is in an area that is inaccessible, still we can go for stereotactic biopsy. We can do the we can get the histological grading of that lesion, and then we can advise chemoradiotherapy for those deep lesions. Prognosis is it is incurable as such, but treatable, and overall survival is about 11 to 15 months. Quality of life, we have to give terminal support to the patient. Quality of life can be for that period you can give at least symptomatic control to the patient. Then after these astrocytomas, we have meningiomas, which represent about 20% of all the intracranial tumors. And as the name indicates, they arise from the meninges, and usually they arise from the arachnoid layer or the arachnoid capsular layer. And they can be WHO grade 1, 2, or 3. They are not malignant most of the time. They have a very slow growth rate. It is classified based on the location. It can be parasagittal, which is along the sagittal plane, and it can be in the tuberculum sella. It can be in the tentorial. It can be in the convexity of the arachnoid and the brain matter. It can be in the saphenite region near the saphenite bone. So its location depends on where it is classified according to its location, and then treated accordingly. What is the location? According to that, management option is different. Clinical presentation is neurological deficit as neurological deficit, scissors. One more thing is these are the tumors of the meninges. So usually they are in the peripheries. They are along the meninges. They are not in the central part of the cerebrum. They are not inside. So they can be anywhere around or inside in these fissures, but they are not in the center of the brain parenchyma. So the symptoms can be neurological deficits depending on its size as well as location, seizures, signs and symptoms of raised intracranial pressure, and sometimes there are no symptoms. They are asymptomatic, but incidentally they are found for investigating while for some other disease. They are being incidentally picked up. Management of these meningiomas is if there are symptoms, you have to control the symptoms. If there are scissor, control the scissor. If there is cerebral edema, try to control it to minimize the symptoms. And these patients, as this condition is not malignant, if the symptoms are not much, and if the surgical resection is not possible in some lesions, but they are asymptomatic, we just keep it on follow-up. If the patient is having symptoms or the lesion is growing, then we have to go for surgical resection. So this is all about these intracranial tumors. These two are the most important ones, the meningiomas and glioblastoma multiforme. They are classified based on WHO classification, can be benign or malignant, and can present in a variety of clinical scenarios, depending on the location of the tumor as well as the size of the tumor and the pressure effect it is causing. It can cause raised intracranial pressure by different mechanisms, and management can be medical, surgical, or combination of or radiotherapy or chemotherapy or a combination of these. Prognosis of the tumor usually depends on the histological findings. If it is malignant tumor, usually the prognosis is not very good. But for benign lesions, if managed properly and if they are resectable, prognosis is usually good. Prognosis, we here we are taking prognosis both in the benign and the malignant, because the benign lesions also they cause pressure effects, and they can be life threatening because of their because of the symptoms they are causing. So you have to treat the patient and the symptoms as according to the histological grade also. Okay, any question from these two varieties of the brain tumors? Any question? Okay, should we start the other one, the other lecture? Should we start the lecture, or you want break again? Okay. The third lecture is about the spinal injuries or the spinal surgery, but we'll discuss only the spinal cord compression syndromes. Just